బాగా ఇన్ఫర్మేషన్ వచ్చిందా నాకు రాలేదు మీ దగ్గర నుంచి గలీజ్ గా ऐसा करे तो कैसा अरे यार अरे One second.
Can you hear me? Hello? Hello?
Yes, yes, ma'am. Audible,
Can you
audible.
hear me?
Yes, yes, completely audible.
Yes,
2 minutes to go, ma'am. Yeah, you can keep your camera on. 2 minutes to go.
No. They just attach me to a speaker. That's why I'm testing it.
One minute to go, ma'am. Sharp at 2, we will start.
Okay.
Yes, ma'am.
Okay.
It's sharp 2, ma'am. So with all your due permission, shall we begin? Good afternoon, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent stalwart for today's session. Well, she's none other than the very renowned obstetrics and gynecologist, Dr. Tripura Sundari, ma'am. Ma'am needs no introduction, but yet it's our great pleasure and honor to introduce her. She is MBBS, MD, DGO, FIMS, consultant and HOD at obstetrics and gynecology at Kims Hospital. So with ma'am wonderful experience and with her wonderful insights, we are going to talk about the topic for today's session, which is contraception, which is going to be an informative webinar that covers the wide spectrum of contraception options available today. So now without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you.
Good afternoon, everybody. I think on a warm winter afternoon, we are meeting on a very important topic, contraception, and how to avoid unplanned, unnecessary pregnancies, which is a major problem both for the society and for the couple and for the lady in particular. So today we're going to talk about what is contraception to avoid unwanted pregnancies. So if you think of current status in India, we are only 2.4% of the total area, and the population is around 15%, the second largest. And the demographic gap, you see, birth rate is almost equal to death rate. At our place, it is birth rate is more than the death rate because of early marriage, decrease in literacy, and absence of family planning, and hence we need a population control. Why more children? We have a racism, God's gift we think, preference of sons. So unless you have one son, you 7, 8, 9. The other day I did a section for a patient, a 7th gravida, she has 6 girls. And to her bad luck or to her good luck, she was blessed with one more girl, and refused is for her. That is the status in our this thing. And economic gains, more children go to work, everybody gets some money to run the family, but they don't think of the future of the children, about their education, about their health. And fear of mortality. If you have more children, when 1 or 2 die also, you will be left with some children. And absence of family planning concept is not there. Maybe it is against the God's gift, so you do not drift us. So what should you do? Comprehensive family planning program is there, a national health policy, proper spacing and limitation of birth, and their parenthood should be counseled, and screening of the fetus, help unmarried mothers, MCS services. So these are very important to be done. So if you delay a child from 18 to 25, 5 years delay, also will bring down only 10% of the population. We should be impressed by them. The reason we are encouraging late marriage, late means nowadays we are having marriage at 35, 30, that's not late marriage, at least around 24.
You can share your screen again, ma'am. Yes.
Can you
yes,
see?
Yeah, I can see you now. You can share your screen now, ma'am.
Screen sharing is not coming. Leaves. Screen sharing is not been seen, no?
No, ma'am, it's not yet shared. From share screen option, you have to share the screen, ma'am.
Okay. Okay, can you see now?
Yes, ma'am, now it's visible.
Okay. So this is the method, the pregnancy occurs, all of you know. And and the menstrual cycle, you all know. So with that, you know, when you have to protect this pregnancy, where you should interfere. So without protection, if you see 85% in 100 women will get pregnant without any protection, and you want 99%, 100% may not be possible, 99% efficacy contraception are air. So you've got long-acting reversible contraceptive, that LARC, which are having about 99% efficacy. Short-acting reversible contraceptives like contraceptive injections and Nova Ring or combined oral contraceptive long-acting pills are there, which is again 91%, and you've got other contraceptive method, the barrier, which is 76% effective, that is diaphragm, male condom, female condom, withdrawal method. So you have to choose between them which to use. So methods of contraception are temporary, that is barrier, IUCD, hormonal post-contraception, and permanent, that is vasectomy and tubectomy. So all cafeteria method, you have to tell the patient what are all the available, and you have to advise them as per the advice and need. If it's short, if they're having only, sometimes patients come to us saying, my husband is coming down for a short visit of 2-3 months. So in such patients, there is no point in giving them a long-acting UCD. You can give them a simple injection. Or patient is an occasional visitor. The patient, people have once in 15 days, 20 days, you have to get there. You can still advise them of condom. So depending on patient requirement, you have to advise. Best contraceptive is nowadays you have, the patients are out. Husbands are outside, the wives are in India. Ones, male medicated latex scented are available, and female, again you got female condom is there. Condoms, they are cheap, easily available, easy to use, safe and reliable, and it also protects against AIDS, HPSAG, HCV, and other sexually transmitted diseases. Hardly any side effects, but variable acceptance. The thing is, it should be properly used, and every time it should be used, and there may be slipping or bursting of the condom, which may result in a failure rate of 12% if not properly used. Next, coming to barrier contraception, other things like condom, diaphragm, and sponge. Chemical suppositories as today are also available, and you can use both together. The efficacy goes better. That is, both today tablets and condom used together, the efficacy will be better. This is the one, the choice for the female. This is a today sponge which can be used at the time of contraception. Next comes spray-on and gel. This progesterone and best for lactating mothers. Spray-on gel stated in its use in 2004 in Australia. It is not available with us. Preset dose of fast-drying hormone to the skin. Spray is absorbed instantaneously. Gel is applied to skin daily. Hormone is connected as a reservoir within the skin and slowly diffused into the bloodstream. This is, I don't think, available in the regularly in the market. Disadvantage is there may be application site reaction, not very effective in obese women. Side effects similar to OC pills, cannot be concealed, and no protection against HIV or other STD infections. The other thing is patches, transdermal systemic transdermal system of combined contraceptive, that is EVRA. Contact surface area is 20 square centimeters, 6 milligrams noradipine and 0.75 milligrams estradiol are released daily. Continuous systemic dosage of 150 micrograms is there, and the peak levels are seen within 48 hours of the placement. It can be weekly delivery and dosage. It bypasses GI. So when the patient is very obese or having any GI, liver problems, this may be a choice. But in our society, where it is a humid nature is there, because the sweat, it usually gets dislodged and the effectiveness comes down. It may be applied on the buttock, outer upper arm, or back, or lower abdomen, and upper chest. So just by applying, you can conceal routinely from where it is used. The advantage is once you apply, it works for 3 weeks. So patient did not have the tension of taking the pill regularly. So a 3-patch system starting on day 1, apply 1 patch each week for 3 weeks. Apply each patch in the same day of the week. 1 week is patch free. A weekly application, easy verification of presence, contraceptive effects are rapid, excellent cycle control after 3 months. So for initially there may be irregular bleeding. After 3 months, it is very effective. So it is a backing layer, flexible film is there, provides structural support, protects middle, adhesive layer from the environment. The middle layer is active, hormonal components are there. Third layer is release liner, protects adhesive layer, removed just before the applying the thing. Next is an O-ring, vaginal delivery of contraceptive hormones. Flexible, smart, transparent ring is there, ethinyl vinyl acetate, and outer 54 millimeters, cross-section diameter is 4 millimeters. Ethinyl estradiol 2.5 milligrams, testosterone 11.5 milligrams. Uniformly displayed. This also has to be applied within the first few days of the cycle and removed at 25 days. So this also keeps inside, and there is no botheration of keeping it daily and taking the tablet daily. And but thing is, the cumbersome, it has to put in the vagina and remove regularly. Next comes IUCDs. There are first generation, second generation, third generation, and Marina. The Arena acts for 5 years, needs minimal expertise and complications. It's cost effective, helpful, and for correcting anemia, dysmenorrhea, AUB, and HRT. Hello? Hello? Can you tell me? So next comes there are different changes of IUCD. When we were students, that time only 10 years before the Lippis loop was there, we were removing Lippis loop. That was only a S-shaped multi-helical thing what was there. Now it has changed slowly and has come to what is called copper 380A. Copper 380A is having the copper on the arms on the T. So that acts for 10 years, and out of all the different varieties available, that is the cheapest, best, easily available, effectively acting for 10 years. It is available even in the government setup, free of cost. So it is the best thing that can be used. Next is called Marina, that is a hormonal contraception. See, COT380A, as I told, is effective at 10 years. It is intrauterine insertion is there. It can be done immediate postmenstrual, post-abortal. PPIUCD is very effective in that the patient immediately after delivery, the cervix is open, the uterus is all big. So there is no need for the patient. You can counsel the patient during the time of labor itself. You can take the consent and insert the IUCD at the time of delivery or during cesarean section. And these threads will be, of course, will be coming out that can be cut after the postnatal visit. But this patient has to be counseled well, because so many times they come back after 15-20 days saying that they want the copper to be removed. So this is, but even if the government of India policies, even if 10 people are given the PPICD, even if 8 also, at least 2 will be having them. So it is a good policy to be continued. So available free of cost government setup. Disadvantages are fear of migration, perforation, intermittent spotting. Of course, this does not prevent ectopic pregnancy. Now, hormonal contraception can be oral or depot preparations. The oral can be combined pill, the mini pill, postcoital pill, once a month pill, and gossipol, that is a male pill. Depot preparations are injectables, implants, and vaginal rings. These combined oral contraceptive pills are very useful, not only for contraception, for prevention of anemia if the patient is having heavy menstrual bleeding, or correction of the cycles if they have irregular bleeding, and patient will have a small adenomyosis or endometriosis also, this can be used. Now, LARC. LARC is long-acting, reversible contraception. It is very useful. All the things available as one is IUCD, another is that is copper T or Marina, injectables at Depo-Provera, implants Implanon, and then vaginal rings. Injectables at Depo-Provera works for 3 months, cheap and effective, that is 99%, irregular spotting or amenorrhea, and patient may have mood swings, dryness of vagina, causes reversible osteoporosis. This should be always understood and usually used for more than 4 injections, not advised, because patient will feel the menopause symptoms more frequently. Implant, that is Implanon, is available in India for the last 3 or 4 years. Implanon is subnormal implant, works for 3 years, is cost effective, contains 16 millimeter nostril, released over 3 years. As it is subdermal, non-invasive, easy to counsel. It's an OP procedure. Insertion takes hardly 1 minute. Removal takes 3 minutes. Reversibility of fertility is immediate. Usually, ovulation occurs in the next cycle itself. This Implanon comes with reloaded syringe, and it has been given here just below the this is in the groove, and it can be inserted in the OP itself by giving a small load of xylocaine, small, no need to give any nick also, and you just pierce it and inject it. But when you want to take out, you just see where it is placed, give a small link, with the forceps you take out. So that is an easy method, and Implanon is very useful, especially when they want for a short period of say 2 to 3 months, 2 to 3 years, sorry. Next comes Senpraman, Saheli, that is Orloxafin. It is non-steroidal, once a week pill, disturbs endometrial preparation, 30 milligrams twice weekly for 3 months, followed by once weekly for another 3 months. This corrects AUB, adenomyosis, breast tenderness, fibroadenosis, and we use it in the fibroadenosis also regularly. Contraindications is recent jaundice, PCOD, and for nursing mother you have to think twice. And it's always better to do an LFT and a scan before you advise Saheli. This is not much used, liver to be checked, so you have to be careful by giving that. But again, this is also very useful, and patient will make on to amenorrhea in this also, and it's quite easily available and accessible to be easily because only once in a week it has to be taken. So patient acceptance is better. Next comes LAM, that is lactational amenorrhea method. This is one of the best methods for nursing mothers. Baby gets 85% of the food feed from the breast milk. At least one feed should be in the night. So that means patient is getting stimulated with the suckling almost 24 hours. This and there should be amenorrhea persisting. Up to 6 months it is useful. So longer the period of breastfeeding, more of LM effective. That is, lactation increases prolactin. Prolactin decreases there's no ovulation. So patient will be amenorrheic and patient will be lactating, and there may be contraception. But one should be very careful. This amenorrhea, if you think during that period itself, they may conceive. That's the reason we say the patient should be totally being fed by the mother's milk, including in the night. No, not even water should be fed to the baby apart from the milk, and they should amenorrhea, but you should check in between. So it's effective for the first 6 months, encourages breastfeeding, no cost involved, no planning, no side effects. Baby gets best food and attention from the mother. There is a good bonding between mother and the child. But effective only in established lactation, not suitable working women, no protection against STD, needs another barrier contraception. Next comes when you are planning everything is okay. When an emergency contraception occurs, then there is a problem. This is up to 72 hours. You can use Maladi 4 tablets plus oral 2 tablets, or followed by after 12 hours if you are saying Maladi 4 tablets plus oral 2 tablets, or you can use iPill, or monthly period may be altered by taking these tablets, and follow family method may be advised. The thing is, you should have to educate the patient. This is again a big problem. Patients start taking the so-called emergency contraception, IPL also. Every time they have an unprotected intercourse. No, if the unprotected intercourse occurs during the fertile period only, this should be taken. I've seen patients taking it almost 4 or 5 times a month, resulting in irregular periods and AUP. So you have to be, patient must be having patient having regular periods, she can avoid the fertile period, and during a fertile period, if they have unprotected sex, only then this should be used, and this is the dose, either IPL or you can do Maladi. So follow-up method may be advised in following this 4 tablets, because after that also patient may be having irregular periods, either condom or continue the OC pills for the remaining period of the cycle. If all these things we use, it fails, comes to medical termination of pregnancy, this unwanted pregnancy. First trimester, you got, nowadays we are simply using mifepristone, misoprostol, and patient is not willing for that, you can use suction evacuation, or simply you can use menstrual regulator, one-time procedure. With this mifepristone, misoprostol, it's an OP procedure. Patient doesn't need admission, and there's hardly any bleeding. A single scan initially to see whether it is intrauterine pregnancy or not. Then you give mifepristone for 48 hours of misoprostol, and usually the patient aborts 90 to 94% total abortion occurs. So you see a check scan after 2 weeks to see whether the uterus is empty or not. And if there is needed, you can repeat the misoprostol, or you can do a simply small check retouch. And if that is not possible, a single time procedure, if it is less than 6 weeks, you can still use a meson regulator, one-time procedure, it will be totally evacuated. If it is 8 to 10 weeks or up to 12 weeks, you can use suction evacuation. This also, if you give misoprostol before the procedure, the os easily opens up. Suction evacuation will be safer for the patient. Comes the second trimester, immediately we are using you very nicely, but somehow it's not available now. So you can use again mifepristone, wait for 48 hours, and a prostaglandins you can be given, provided it's not a scarred uterus. If it is scarred uterus, you can put a catheter, wait, once the dilatation occurs, you can clear. Or if it is a previous 2 sections or 3 sections, and there is the cervix is not favorable, if you are going to combine with tubectomy, you can do hysterectomy, but hysterectomy should not be a choice. The patient is multi and she wants a permanent sterilization, you can go for tubectomy, which can be postpartum, post-MTP, you can combine it with LSES, cesarean section sterilization, or it can be a cold sterilization, which can be vaginal, which we are not using much. You can do mini laparotomy, which is usually done in the small setup, or you can do laparoscopic, that is DPL, is now done even in camps at PSCs or in all major hospitals. That is a very short, half an hour, about 15-20 minutes procedure. Patient can go home the same day, and patient has minimal. She can go back to her work also within 48 hours. So this is the surgical. You can go laparoscopic, you can use bands, or you can use laser, or you can use diathermy, by which you can have an effective this thing. Or sometimes the patient is having bad hydrosalpinge or infected tubes, you can do what is called a salpingectomy, which prevents future hydrosalpinge. Or you got what is called hysteroscopic sterilization, which is not widely available in India. The Assure is sterilization method. Microcoil is placed in the both fallopian tubes ostia. The sterilization method, Celaxone material placed into the tubes via the catheter. This is the preloaded one. Once you do hysteroscopy, just put this thing at the ostia, both the ostia, then just trigger it. It will get slowly released into the tube and it gets solidified within a short time. But patient has to follow that some control method at least for the next 1 or 2 months, but it's a permanent method and its microinsert system will close both the tubes, but it is an OP procedure and patient can be discharged the same day, no cut on the body. This is the Assure system where you see the ostia and just inject the dye. So we're not talking from all this while about the female. So how about me? The male also wants some treatment. So you got male sterilization, that is a vasectomy, open method, cut the vas in scrotal by posterolateral incision or bilateral. All pulverization, what vas is identified, kept in pulverizer, gas gets crushed. And no scalpel technique is the one which you are following. Fine needle is introduced in the posterior half of the scrotum. Isolate and cut, no suture needed, it's only the now new male contraceptives are available. Like vas, this is the thing you have got cross section of the tube and the silicone plugs are inserted into the each vas deferens. These are not regularly available. You got so many advanced, added on this contrast methods, the contraceptive jewels. The small earring thing, you can just put it onto the skin, it gets absorbed, and patient is, can keep it as secret. It's there, it is there almost for 1 month. He keeps on changing it every month, and it's a constant drug, and patient secrecy is maintained at the same time, her beauty is maintained, and contraception is there. Like that, we have got small rings, intrauterine rings, which can be placed in the thing, which also occurs a short period. So all the advances on the contraception which we have now. So with this, we can have the patient a choice as per a requirement, whether she wants a short period or if she wants a longer period, whether you should use whether she's obese, if she's hypertensive, whether liver disease is there. Depending upon that, we have to choose the method of contraception, and we can give a cafeteria technique to her, whether she can choose, whether she is scared of the drug, whether she can take her education status, her economic status also should be taken into account, and we have to tell the things. So include family planning methods in the curriculum, scientifically train doctors family planning methods, encourage research in indigenous medicine, involve doctors and medical students in active family planning program by which patients know, and the doctors also should know what you should advise for which patient. If you say a villager who comes to you for contraception, if you tell her Marina, one thing is it is costly, patient will not understand. And if you say patient wants for a short period, if you tell her I use a this thing for 3 or 4 months, you can, if you ask her to take a this implant on fast, and she may not be able to afford. And if an uneducated patient, you say regularly you take on the second day or third day, or regularly same time take tablets, you may not be able to take. The patient had already 3 or 4 children, wants permanent contraception, property might be a best answer, provided there is no AUB or patient is not having any chronic sinusitis. So the patient is having AUB and small fibroid, adenomyosis, pain is there. For such patients, of course, Marina will be useful. So you are taking into consideration patient education standard status, her this economic status, and how frequently she can reach you, and how she can inform you about her problems. You have to choose the contraceptive and give. Thank you.
Thank you so much, ma'am. Thank you for sharing a wonderful insights with us on this important topic that you have shared. We have a few questions for the participants, ma'am. For your information, I would like to put the process questions to you. Hello. Ma'am, am I audible? Hello.
Not audible, ma.
Yes, ma'am. So I'll pick up the questions to you one by one from the viewers, and you can reply to those questions.
One.
So the first question is, what are the risks and
Strike it,
consequences of
I
contraception in high risk
gave
women? Hello.
1 minute, 1 minute.
Yes, 6 minutes.
Hello.
Audible? Hello.
You're not audible, ma.
Hello.
Yes.
Yeah, am I audible?
No, no.
Hello.
Yes.
Yes, we can hear me, right?
You're not audible, ma.
Hello.
Your volume is very low.
Ma'am, you have to increase your volume from your end, ma'am. From my end, the volume is at high pitch.
Okay, wait.
If you're trying to say something back, then I can't hear you. Now I can hear you.
My volume is full, ma.
Ask if they can hear you.
Your input level is low. My microphone is okay.
Can you hear me now, ma'am? Hello.
Hello.
Yes, ma'am. Now am I audible? Hello.
Here, available.
One minute, ma'am.
Yeah.
I'm not done. అది ఇంకా ఏం కావాలండి ఫస్ట్
I'm trying to log in through my cell.
Yes.
Now it has come. See, what do you do?
I
Now you are audible.
okay. So shall we start with the question answer session?
Okay. Now you
Ma'am, we have joined with two devices, so you have to mute one device.
Yes.
Yes, ma'am. Right. So can we start with the question answer session, ma'am?
Yeah, please.
Yeah. So the first question is, what are the recent guidelines for contraception after medical abortion?
See, medical abortion, when we do, usually for myself, I try to wait for the next period to start come. But the many patients may conceive in the next 15-20 days itself. So better we advise them barrier contraception for the next period. Or if you are sure that she has completely aborted, you can put them on OC pills for the next thing. The patient is, some people advise IUCD, but I don't, because the spotting, if it is occurring, is because of the remnant RPOC or because of the IUCD, you will not know. So better is patient can continues with the barrier contraception till the next period. Or if the patient is completely aborted, you can give her a single dose of Depo-Provera, which covers for 3 months, and then she can go for the next advice. Again, this depends upon the patient's age, a requirement. A young patient, if you give Depo-Provera, she may be having spotting. And elderly patients say around 34, 35, and amenorrhea may be welcoming. So you have to again choose the contraception as per the patient's requirement. One thing is there, guidelines are used for guide us. You have to again select the method as per the patient's requirement and as per your experience.
Thank you so much, ma'am. Thank you for answering that question. We will take up the next question that we have received. And the question is, what are the hormonal and intrauterine methods for contraception for women aged 25 years and below ages?
See, we were using Marina initially for AUB, but now we are using Marina, that is the hormonal contraception, even for contraception. So this hormonal contraception can be used even for these young patients, and I have used it quite a number of patients, and this is over for 5 years. It acts, but you can use for 2 or 3 years and take out. This again brings down the AUB level, and the patient is having less bleeding, and as such she may is sure of the contraception, and we can use it for a long. Only thing is it is not available in the government setup, and it costs around 2,500, 3,000. So if you use that, this can be a very effective and not only for contraception, for also for parent. The other thing which is hormonal contraception, we can use injective, that is implant, that is the Implanon, that also acts for 3 years, and it is still less, it costs only some 2,500, and it is still just at the hand. And the young patients usually are preferring that because they can feel it, nothing is introduced into the uterus, the fear of migration or perforation are not there, and it's an OP procedure, and they can just get it taken out immediately after 1 or 2 years. And the reversal of contraception, that is, patient may conceive and get a period within a month of removing Implanon. So patients are accepting it. So these are the two hormonal things which are useful. That is, one is Marina intrauterine or Implanon, you can use it. The rings are there, but somehow the acceptance is not that much.
Thank you so much, ma'am. Thank you for telling about this question in details. We'll move to the next question that we have received. And the question is, what are the alternatives to oral regimens of contraception?
Pardon me?
The question is, what are the alternatives to oral regimens of contraception?
So the alternative for oral is the best when the patient is educated, can take regularly, especially when she is having irregular periods or when she is having AUB, that is heavy menstrual period, or dysmenorrhea. Alternative to that is, of course, injectables and implants, which again are not useful, very useful in contraception, but patient you have to consult. She may have intermittent spotting, or patient may be going to amenorrhea. Single injection of Depo-Provera, as patient had gone almost 1 year of amenorrhea, it took a lot of time for us to revert her by giving estrogen, progesterone, sequential pills, 3-4 cycles to bring her back to regular period, especially young patients for 1 month of 1 year of amenorrhea is not acceptable, not only socially, but even otherwise also she will go into what is called a reversible menopausal symptoms. So these things have taken about. So OC pills are good, but if you want alternative OC pills, you have got the injectable and implants, and these are the side effects which they have.
Thank you so much, ma'am. Thank you for answering that question. That was the last question for today's session. And
Thank you.
with this, I would like to thank all the viewers and you, ma'am, for taking out your valuable time and for being here at our platform and sharing your experience and your insights with us with your wonderful presentation. Thank you so
Thank
much,
you.
ma'am. With
Thank
this, we are
you. Good
concluding the
night.
session here.